The thyroid gland is located in the mid-neck and overlies the trachea below the larynx. It has two lobes which are connected by the isthmus. The hormones that are secreted by the thyroid gland regulate metabolism and regulate calcium. Blood supply to the thyroid gland is from the superior thyroid artery, which originates in the external carotid, and the inferior thyroid artery, which originates in the thyrocervical trunk of the subclavian artery. The poles of the thyroid are where these arteries enter the gland and are an important anatomical landmark for surgery. The recurrent laryngeal nerve must be protected. If injured bilaterally, acute paralysis of both vocal cords may obstruct the airway and require an emergency tracheostomy. The parathyroid gland usually consists of four small oval masses, with the upper ones generally being smaller than the lower ones. They all receive their blood supply from the inferior thyroid artery, and their purpose is to secrete a parathyroid hormone to maintain calcium hemostasis. The thyroid gland is assessed by the patient's signs and symptoms, blood work, palpitations, scans, and fine needle aspiration. The parathyroid is assessed by blood work and looking at the signs of dysfunction. An enlarged thyroid can cause challenges to the anesthesia provider, and a difficult airway cart should always be present. Surgery of the thyroid and parathyroid can also compromise the airway, and tracheostomy set and supplies should be in the room before the case starts. The recurrent laryngeal nerve will be located using a nerve stimulator. These procedures often require that many specimens. So it's a team's responsibility to make sure there are many specimen containers available and always labeled correctly. For surgery to the thyroid, usually the patient is placed in the supine position with the arms tucked and the neck hyperextended for maximum exposure. The prep parameters for these procedures are chin and anterior neck region, lateral surfaces of the neck, from the earlobes down to the outer aspects of the shoulder to the bed, and upper anterior chest region to the nipples. All previously learned positioning and prepping precautions apply. The body has three pairs of salivary glands: the parotid, the submandibular, and the sublingual, and many minor salivary glands are found throughout the oral cavity and pharynx. These salivary glands produce saliva that irrigates the oral cavity and contains enzymes that break down simple carbohydrates, and has buffers that reduce acidity in the mouth and protect against some bacterial and demineralization of the teeth. The parotid is the largest, and the facial nerve passes through this gland. The submandibular gland is the second largest salivary gland and is C-shaped and wraps around the lower border of the mandible. A branch of the facial nerves lies within the superficial fascia of the gland. The hypoglossal nerve and the lingual nerve lie beneath this gland. A parotidectomy is the removal of the parotid gland. Most pathological disturbances occurs in the superficial parotid lobe. If the deep lobe is involved, there's usually a malignancy. However, most tumors of the parotid are benign. Parathyroidectomy is the excision of one or more of the parathyroid glands. They can be removed by an open operative procedure. This approach is similar to the open thyroidectomy, with the thyroid gland rotated to provide access to the parathyroid glands. Minimally invasive focuses on parathyroid procedures such as PTH-guided parathyroidectomy are becoming more mainstream. Thyroidectomy is performed to treat known or possible malignancy or for the treatment of hyperthyroidism. Benign enlargement of the thyroid is called a goiter and may compress the airway or esophagus. With Graves' disease, the thyroid overproduces hormones and the patient may have a portion of the gland removed or treatment with a radioactive iodine. A thyroidectomy is usually a total thyroidectomy with the entire gland removed, or a hemothyroidectomy with the incision of one lobe and the isthmus. A thyroidectomy can be performed with an open procedure or by minimally invasive method. Regardless of the approach, the principles are the same. This area is very vascular, so it's important to maintain visualization and prevent nerve injury. Suction and many clamps will be used. A thyroidplasty involves moving the vocal cords to one side and stabilizing it with a Celastic or Gore-Tex implant. Unilateral vocal cord paralysis is the main reason for performing this procedure. The most common method is to fix the paralyzed vocal cords in the midline so that moving the cord can just push against it. Neck dissections are done to remove the affected structures of the lymph nodes to halt the spread of disease. Many head and neck cancers metastasize to the cervical lymph nodes. The radical neck dissection involves the removal of all cervical lymph nodes and surrounding structures, including the spinal accessory nerve, the internal jugular vein, and the sternocleidomastoid muscle. The modified neck dissection is the removal of the neck contents except for the sternocleidomastoid muscle, internal jugular vein, and 11th cranial nerve. A glossectomy is the removal of the tongue. It's usually performed for the diagnosis or treatment of cancer. A hemiglossectomy is the removal of less than half of the tongue and is used for diagnosis. A total glossectomy is the removal of more than half of the tongue for treatment of cancer. A total laryngelectomy is usually done at the same time to treat laryngeal metastasis or problems with aspiration. A laryngectomy is the removal of the larynx or voice box. It can be partial, which is the removal of a portion of the larynx, or it can be total, which is the removal of the larynx, hyoid and strap muscles, and may be a pre-epiglottis space. Depending on the surgical defect, reconstruction surgery will vary. Sometimes a flap is needed to close a wound. A pectoralis myocutaneous (PMC) or a deltopectoral (DP) are common flaps used for reconstruction after neck dissection because of the proximity.